Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out the Real Life Pharmacology Top 200 Study Guide. It's a 31-page PDF, great refresher on things that show up on board exams, as well as common things you'll see in practice. So, simply an email will get you access to that at reallifepharmacology.com. All right, let's get into the drugs of the day today, and that is 166 through 170. First one we have is oxycodone acetaminophen combination. Brand name is Percocet. I see it most commonly used for post-op pain, that type of thing, but can be used for various pain syndromes. Mechanistically, acetaminophen, I think I've covered that in the past. Oxycodone is a full opioid agonist. So it's got that activity by stimulating mu receptors in the central nervous system, which ultimately provides that analgesic effect or pain-relieving effect. So I'll focus a little bit on the opioid, the oxycodone portion of it, class risks associated with opioids, constipation. Many patients, if they're on longer-term opioids or even shorter-term, will need some laxative-type medications to keep things moving. Oxycodone can also cause some nausea and GI upset, that type of thing. Obviously, sedation, confusion, CNS effects certainly can happen with opioids, particularly as we escalate the dose. That's more and more likely. Respiratory depression, as we get closer and closer to toxicity levels, overdose situations, this is more and more likely to happen and ultimately can be fatal if doses are too high. With opioids in general, there's generally no ceiling dose if it's titrated up slowly over time, and that's due to tolerance. So patients get their body gets used to taking higher and higher dosages over time. And so that can be a challenging thing to kind of deal with for sure. And then, of course, being a controlled substance, risk for dependence, risk for addiction. In certain situations in geriatrics, obviously we don't worry about that maybe quite as much. So let's say you've got an end-of-life situation, where maybe they have 3 months, 6 months less to live. In that situation, we probably don't have as high a concern, for dependence and addiction and those type of things because, the life expectancy is low. So, again, there's kind of always a risk versus benefit type of thing when dealing with that, particularly in geriatric patients. In younger patients, I've heard people kind of say every opioid should hopefully have an exit strategy of getting them off that opioid. So, really do whatever we can to use these in the short term, only if possible, and try to minimize dosage, use them for as short a period of time as possible because, patients do start, to develop that dependence fairly quickly. In practice, I've had to, try to convert people sometimes from various opioids from one to another. Definitely not a perfect way to do it. Pharmacogenomic variations, pharmacokinetic variations. So, a ballpark equivalent of oxycodone, 20 milligrams is approximately equivalent to morphine 30 milligrams. I'm a little hesitant to say that because you got to take that with a grain of salt. Patients definitely can respond and react differently based upon, again, pharmacogenomics, pharmacokinetics, and things like that. So that's an approximate equivalency that's typically kind of standard in practice or well known anyway. Again, those pharmacogenomic differences may impact metabolism, again, making those conversions imperfect. On the acetaminophen portion, I wanted to mention probably the biggest thing I worry about, particularly in combination acetaminophen products, is patients taking other products with acetaminophen in it and not recognizing, like, hey, I'm getting Percocet. Well, yeah, it's an opioid, but it also has acetaminophen in it as well. So not recognizing that, then taking over-the-counter Tylenol, cough and cold medication, and so on and so forth, we can run into certainly liver toxicity. From a drug interaction standpoint, CNS depressants I definitely worry about, benzodiazepines, gabapentinoids, pregabalin, gabapentin, other sedatives like Z drugs. We can run the risk of respiratory depression and basically increasing kind of the overdose symptoms, overdose risk with opioids when we use these CNS depressants in combination with one another. And then hepatotoxicity I kind of alluded to, taking it with other medications that contain acetaminophen, but also potentially interacting with patients that maybe have pre-existing liver disease, or maybe they're have trouble with alcohol use disorder, things like that. With oxycodone, CYP2D6 plays an important role. Interestingly, CYP2D6 inhibitors can actually reduce efficacy of oxycodone. So that's kind of alternative compared to what we're used to. So why that is CYP2D6 actually converts oxycodone to a more active form of oxymorphone. Okay, so classic example of a CYP2D6 inhibitor is bupropion. Now, CYP3A4 plays an important role in breaking down and basically shutting off the action of oxycodone and oxymorphone, the active metabolite. So any CYP3A4 inhibitor will actually be more likely to increase the activity of the opioid, the concentrations of the opioid there. All right, moving on. Next medication is Epogen. This is epoetin alfa. Epoetin, if you remember, it induces erythropoiesis. It induces the release of reticulocytes from bone marrow into the bloodstream. And ultimately, this is the production process of red blood cells. So one common situation where we don't get that production is in chronic kidney disease. The kidney plays an important role in red blood cell production, and if the kidney is damaged, like in CKD, we may not get that much endogenous production of erythropoietin. So erythropoietin stimulating agents, or ESAs, or they're often abbreviated as, like Epogen or epoetin alpha. Probably the two most common settings I see these medications used for are oncology purposes, to stimulate red blood cell production, where obviously we're hurting, damaging that bone marrow. It's leading potentially to anemia. The other common situation is CKD, or renal disease, which I alluded to as well. Adverse effects, biggest one I've seen tested on board exams, things like that, there is a boxed warning for cardiovascular events. So we really don't want to get too aggressive with the treatment of epoetin. If we correct that hemoglobin too much or too quickly, we can increase the risk for cardiovascular events, which is obviously a big negative thing. Patients, as we get to higher and higher hemoglobin levels, they were at greater risk for death and serious cardiovascular reactions. So typically, when giving ESAs, we don't go above a target hemoglobin level of 11. Again, this may vary based upon, clinical desires, clinical outcomes, patient response, that type of thing. Maybe we target a level of just above 9 or 10 in some situations, and maybe we target slightly higher in situations as well. But again, the higher that's pushed, the more and more likely that we're going to run into potentially those negative cardiovascular effects. ESAs like epoetin can exacerbate hypertension, so it can raise blood pressure. Also, the injection can cause some GI upset sometimes, and some arthralgia, muscle soreness. Those are a couple things you may hear patients complain about as well. One really important thing, definitely another highly testable question, is iron stores. So for red blood cell production, we need iron. And if patients don't have adequate iron intake, adequate iron stores, we're not going to be able to produce red blood cells no matter how much epoetin you give them. Okay, so we need iron to do that. So Checking ferritin is something that's ferritin in iron stores is something that's commonly done to make sure that that's adequate, and supplementing with iron may be necessary for patients there as well. So definitely something important to pay attention to. Again, that goal hemoglobin, may vary based upon symptoms, clinical discretion, risk of cardiovascular events. Dosing, I'm not going to go into too extensively here, but usually reductions or increases are by about 25%, and that's done in response to monitoring hemoglobin. So if it's greater than 1 gram per deciliter in a 2-week period, then we might back off the dose 25%. If it doesn't go up by greater than 1 gram per deciliter in a 4-week period, then we might increase that dose by 25%. From a drug interaction standpoint, we don't worry about that too much in general. Probably the hypertension thing is one I worry about the most, and then potentially any drugs that can maybe increase cardiovascular risk. So kind of a classic example is androgens like testosterone that might have an additive or hypertensive effect. Are you looking to take your career to the next level? Go check out meded101.com/store. We've got board certification study material that can help you prepare and pass your exams. Pharmacotherapy, geriatrics, BCMTMS, ambulatory care, NAPLEX exam. Go check out meded101.com/store. Support the Real Life Pharmacology podcast and help prepare to pass your exam today. All right, next medication is Seroquel. Generic name is Quetiapine. This is a second-generation antipsychotic. Remember that antipsychotics in general, or most of them, block dopamine 2 receptors. The different agents block it to a varying degree. Haloperidol, a first-generation antipsychotic, is a super strong blocker of the dopamine 2 receptor. Quetiapine is actually not quite as strong. So I'll talk about that a little bit with adverse effects. Antipsychotics, that selection is based upon kind of multiple factors. So that's the adverse effect profile, convenience, dosage forms, adherence, cost potentially as well. From an adverse effect standpoint, in general, the class of antipsychotics cause sedation. They can cause QT prolongation risk, metabolic syndrome, extrapyramidal symptoms or EPS, hyperprolactinemia. They can increase the risk of falls, tardive dyskinesia in longer-term use, or particularly when trying to reduce or taper off medications. Very rare things, neuroleptic malignant syndrome. It's very rare acute reaction, usually at higher doses in younger patients. There's also a boxed warning for increased risk of death in the treatment of dementia-related behaviors. Now, do I still see it used in this setting? I do, occasionally. So that definitely has to be a risk versus benefit thing, and the behaviors that we're trying to manage with antipsychotics. We better make sure that the medication is actually working, and that B, those behaviors that we're trying to treat or manage are harmful to the patient and or someone else that they're around. And so I could definitely do a master class on geriatrics and management of behaviors using medications for sure. But anyway, I won't go into that any further here. All right, Quetiapine specifically, I alluded to that dopamine blocking effect. It's one of the weaker ones on dopamine blocking. And so that means that it's got a lower risk of extrapyramidal type adverse effects. Okay. Now, where that's important, where that's clinically relevant, is in a disease like Parkinson's. So we already have issues kind of with that dopamine balance in Parkinson's disease. So if we block dopamine action, we can actually make Parkinson's syndrome worse. Okay. So bottom line, if a patient needs an antipsychotic and they have Parkinson's disease, Quetiapine is probably one of the first medications you're going to see used. That's basically what it comes down to there. Other notes about quetiapine tends to be maybe a little bit more sedating than some of the other second-generation antipsychotics. Another risk with it is it tends to be a little bit more orthostatic. It might drop blood pressure a little bit more there as well. So if you know you've got a patient, at high risk of falls or high risk of, lower blood pressure contributing to those falls, quetiapine may be a little bit higher risk there. Drug interaction standpoint, I worry about QTC prolongation with antiarrhythmics, for example, citalopram. There's plenty of drugs that cause QTC prolongation, so recognize that additive effect. It can oppose Parkinson's medications. Again, quetiapine is probably less than some of the other antipsychotics, but it can do that. Additive sedative properties, benzodiazepines, opioids, it can exacerbate that sedation adverse effect. And then orthostatic additive effects as well, dropping blood pressure with, patients that are managed on antihypertensives. Maybe they're taking a PDE5 inhibitor, for example, for sexual dysfunction or something. Any medication that can lower blood pressure, we could have some additive effects with quetiapine. All right, Amaryl, generic name, is Glimepiride. Mechanistically, this is sulfonylurea, or classification-wise, sulfonylurea, which stimulates insulin release via beta cells in the pancreas. So we're stimulating insulin release, as you could expect. More insulin is going to lower blood sugars. So this medication is used for type 2 diabetes to lower blood sugar. It is inexpensive. That's probably its one biggest advantage. It is oral. That's a big advantage as well. Two biggest disadvantages with a sulfonylurea like this is weight gain and hypoglycemia. Definitely important things that you're going to be tested on if you're taking pharmacology classes or board exams, is hypoglycemia and weight gain is associated with sulfonylureas. Careful in patients with a sulfa allergy. There may be some cross-reactivity risk there. Elderly particularly can be at higher risk for hypoglycemia due to this drug class, so definitely something to pay attention to there. They can be somewhat effective at lowering A1C, upwards of 1 to 2 points, depending upon dose and some other things as well. But usually that weight gain, that's a problem, and the hypoglycemia risk is a problem with these as well. So these have kind of fallen out of favor compared to some of the newer agents like GLP-1s and SGLT2 inhibitors. From a drug interaction standpoint, I always worry about new diabetes medications being added and that risk for hypoglycemia. That's important to note. CYP2C9 inhibitors can actually increase concentrations. It isn't something that I crazy worry about, but if you got somebody that's having blood sugars around 70 and you introduce a medication that's going to inhibit CYP2C9, you can increase those glimepiride concentrations, and you might drop that just low enough to cause some issues. So important to maybe pay attention to there with any new medications. And then like medications like corticosteroids, like prednisone, these can counteract kind of that blood sugar lowering effect. They'll cause hyperglycemia and maybe reduce the effectiveness of that medication. All right, last medication I want to talk about today, number 170, is tirzepatide. Brand name is Mounjaro. This medication indicated for diabetes as well as obesity management or weight loss management. Also, this is pretty hot off the press as I'm creating this podcast. FDA actually approved tirzepatide for the treatment of moderate to severe obstructive sleep apnea in adults with obesity, and that is to be used in combination with a reduced calorie diet and increased physical activity. So obviously what we're trying to do there is reduce weight to help sleep apnea. So the FDA actually did give it that approval. The other brand name I should mention, sorry, I forgot to mention that, is Zepbound. So that's important to note there as well. Mechanistically, how does this medication work? It's glucose-dependent insulinotropic polypeptide, or GIP, GIP. receptor agonist combined with a GLP-1 agonist, which you're probably more familiar with in some of the other medications like liraglutide and semaglutide. So it's a combination medication, and this helps promote that glucose-dependent insulin secretion, reduces excessive glucagon secretion, and kind of slows down that gut and delays that gastric emptying. Adverse effects, very similar to GLP-1s. So that GI upset, nausea, vomiting, that's going to be the most common adverse effect. As you increase dosages, that adverse effect risk goes up. From a rare adverse drug reaction standpoint, pancreatitis has been reported. Acute renal failure, not incredibly common, but something to recognize there. Also remember there's that thyroid risk associated with GLP-1s and associated with tirzepatide here as well. So that's important to note. Some of the GLP-1s, the dosing is a little bit different. With tirzepatide, for weight loss or weight management as well as diabetes, there is a maximum of 15 milligrams. So that's a little bit different, slightly different than some of the GLP-1s, which have slightly higher dosing, I believe, for weight management compared to diabetes. One last kind of warning, ADR, adverse drug reaction I wanted to mention was the FDA is looking into depression and suicide. There's been some case reports of that. I haven't seen any great definitive data yet, like in clinical trials and that type of thing. But there is an alert saying the FDA is taking a peek at this. For weight loss, at least the latest diabetes guidelines at the time of me doing this do prefer semaglutide and tirzepatide if you've got a patient with diabetes and they're looking for weight loss. These are the most potent weight loss medications. Drug interactions, big important one. Younger females, got to remember, tirzepatide may decrease the serum concentration of hormonal contraceptives. Okay, really, really important. We're educating patients on this, making them aware. And if you're a provider prescribing this, or if you're pharmacist dispensing or educating on this, or nurse or whoever, very, very important to recognize if they're on hormonal contraceptives to prevent pregnancy, because it may increase their risk of pregnancy if they're taking this medication and they think their hormonal contraceptives are going to work. Okay, so very, very important to remember that one. And then other things to think about with drug interactions, hypoglycemia risk. That's going to be additive when you got insulin and sulfonylurea on board. And then the last thing I wanted to mention here was the DPP-4 inhibitors. Don't use them with a medication that has GLP-1 agonist type action. Okay, there's that overlapping mechanism. It's not recommended to use them together. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. Go support the sponsor, med101.com/store. I greatly appreciate that. It helps keep this podcast free and available for all to benefit from. So any purchases of books, pharmacist study materials, anything there on that page will go directly to support this podcast and help keep it available. So I greatly appreciate your support there. If you want to reach out to me, mededucation101@gmail.com. If you love the podcast, please share it. Share it with friends, colleagues, students, anyone who could benefit from pharmacology education. Help us grow the audience. We greatly appreciate that. Leave a rating, review on iTunes, or whatever platform you're listening on. I greatly appreciate that. It helps support this podcast and get more exposure as well. So definitely take a few seconds. Please do that if you would. I greatly appreciate that. With that, I'm going to sign off for today. Thank you so much for listening. Take care and have a great rest of your day.